Good morning, everyone, and welcome back. We're going to go backwards, starting from chapters 5 through 7, I think, as well as chapters 32. So let's get into it. Our objectives are that we're going to be looking at defining the behaviors that are considered an assessment of a person's mental status, describing relevant developmental care related to mental status exam, state the purpose of the mental status exam, then list about 4 components of the mental status exam, maybe take the time to complete a mini mental state exam, and then discuss developmental care for infants, children, and the aging adult. So what is mental status, as we are looking at defining what that means? Well, normally a person is surrounded by different types of events on a daily basis. We go through ups and downs in our lives. Some days are happy events, some days are sad events, and then some days are just relatively in between. So how do we cope during those times? What is our mental status like? So during times when there are mental stresses, we are able to identify the strengths that we have that helps us to cope and to get through those tough times. But mental status is generally a person's emotional and cognitive functioning. Usually we want optimal functioning, where we're able to balance between life and work and school, and we can function relatively well. So we find a good balance between that. Sometimes there is not a good balance, and so that person end up with a mental disorder, which is when the person's response is much greater than the expected reaction to some traumatic life result that occurs. And there are different types. You have organic mental disorders, and that would be from things like substance abuse, psych disorders like schizophrenia, or anxiety disorders. But generally, it is a response that is much greater than what is expected in life event. If, for instance, I end up cutting or lacerating my finger, then I shouldn't be with a small paper cut on my finger. I shouldn't be gowned up and gloved up and masked up in order to take care of that cut. That will be just above and beyond. I don't need contact precaution in order to just go put a band-aid over that small paper cut. So it's the same thing with our mental health disorders. It can sometimes go overboard in our reaction to what happens in life. So mental status, we cannot really look at it directly or assess it like we would other aspects like our respiratory system or cardiac system. Now, we have information inferred through assessment of what the person's behavior is. So we look at that person's consciousness, where they're aware of their existence. Now, if I ask a person where they are to tell me their name, a person without a mental health disorder should be able to give that information. But someone who has a mental health disorder may not be aware of where they are, so they're disoriented. That means, or maybe they're even lethargic or semi-comatose. Means so consciousness is one way that we can give information related to that. The person's language, how they're speaking, their mood, their affect. Person could be depressed, they could be sad, right? Their attention as well. A person that is under a lot of stress, their attention span is very short. And then maybe the person's thought process, is it logical or illogical? And then the thought content, if someone is thinking that they're God, or maybe that they're, a president or a king, that thought content is not okay if they're truly not the president or the king, right? And also the person's ability to store memory. When we get stressed or we have a mental disorder, we cannot lay down new memory. So for instance, we try to encourage students, although your lives are stressful, to do something to help relieve that stress, because if you're too stressed and you're trying to study, none of that information is actually being learned. And then the person's perception, which is the use of their senses. So are they aware? Sometimes people have problems with, say, hallucinations, and it could be that there is a mental health disorder that's there as well. So we can look at all these things in order to infer or get information related to that person's mental status. Infants infants and children, we cannot really separate their mental status. We cannot look at it piece by piece like we would for the adult. We actually have to look at it as one. It's all connected, because it's interrelated. So children, for instance, they really don't know that they're separated from, say, mom or dad. That's why infants end up crying, when mom is sort of out of sight, right? But as soon as they're getting a little bit older, they learn that they're separate from other objects that's in the environment itself. And then by the time children get to be like school age, they're sort of ready to learn. They develop concentration that would aid with learning. And then when we get to the adolescent years, the adolescent can start thinking a little bit deeper. They can think about hypothetical things. Unfortunately, not all adolescents get there, but children, we try to, as much as possible, encourage the development cognitively related to children. Now, there are some issues related to ADHD, and those mental health disorders come into play that we see get diagnosed like during the childhood years, maybe anxiety or depression or autism. Those we see get diagnosed during those years as well. Now, when we get to the adolescent years, and just let me back up a little bit, because suicide actually comes into play, especially in the teenage years, where there's some depression. The teen is trying to find their way through life, not quite an adult, not quite a child, and that can cause some major mental health issues. And so we have a lot of teen suicide that occurs between 12 and 17. The older adult sort of go through some losses, and so grief could be a very common thing in the older adult's life. Chronic problems that they may be experiencing as well, heart failure, cancers, diabetes. A lot of those disorders occur to the older adult, and so they may be struggling as well related to mental health issues. And so sometimes they have sensory losses as well. Maybe it's an eyesight that's, they can't see very well. They have to be wearing glasses, maybe have glaucoma, etc. Or maybe it's diabetes, and they've actually lost a limb because of diabetes. So there are some losses that occur to the older adult as well that could actually cause some mental health disorders. But we have to be sure it's not a sensory issue, versus a mental health issue. So for cognitive functions like orientation, when we're assessing that in an older person, it's generally considered that they're oriented if they sort of know where they are. So we're not very specific when we go to ask a person, do you know where you are today? If they tell you, they don't have to tell you the exact place. I am in a school in Orange Park. No, they can just tell you that I'm in Florida, and that should be sufficient. We make it a little bit broader so that we can incorporate that in a person. If you are asking about time orientation, you don't actually have to ask about the specific time of day. It's 9 o'clock in the morning. No, but if they tell you it's daytime, or they tell you that it's springtime or summertime, that should still suffice, okay? Sometimes when we go in the hospital as like patient, we become very disoriented, especially when the lights are on all the time. I don't know if you guys have ever heard of ICU psychosis. Or ICU delirium. That can actually happen. So we have to continually reorient, especially the older patient. And then some older patients are isolated because of, they may have lost someone, their loved one, and so they live by themselves. That could also cause some cognitive issues with older patients as well. So we do a mental health exam on patients. When do we do a full mental health exam? Well, if someone mentions that the person was fine and then all of a sudden they are acting very strangely, as in maybe they're sounding a little bit confused in conversation, that their thought content is off, maybe their body reaction, they're not sitting upright, maybe they're very lethargic, sleepy, they fall asleep in a sentence. If someone mentions some concern, then that is a time for us to do a full mental health exam on the patient. When we do a mental status exam, we look at patient's appearance, their behavior, their cognition, and thought process. The appearance is how the person is dressed. Sometimes when people have a mental health breakdown, they start getting depressed. The person that usually grooms themselves really nicely, those things go by the wayside. So they'll look very unkempt, face is unwashed, hair is uncombed, they're still in pajamas and not up getting dressed. So appearance is very important to look at. Also movement. If someone is moving like a mile a minute, they cannot slow down, that could be an issue as well. Or maybe someone is moving very slowly or speaking very, very slowly. Then we know something is off. And then that person's, their level of consciousness gives us a sense, that is their behavior as well, and what their face look like. If a person is all of a sudden really happy and then the next minute they're really sad, that means something is off on that individual. There's no quite balance or equilibrium there. And normally for cognition, we look at a person's attention span. So we will give the person maybe 4 words that are unrelated for them to recall, and then ask them what these are in like 4 minutes, in 5 minutes, and then 10 minutes, and then 30 minutes. And a person that has a mental health problem would be not able to recall all 4 words. They may miss words. A person like with dementia, it takes a while for them to remember, or they may be able to remember 1 out of the 4 words. And then the person's thought process really should be logical as well. So normally when we're doing a head-to-toe assessment on the patient, we can make a determination as to what the person's mental health status. If we see that something is off, then we may want to do a full mental health exam. So patients initially are screened for anxiety disorder or depression. Maybe they are having some inappropriate social interaction. That'll give us a concern as well. Family members are concerned. We need to be able to screen, do a full mental health status. Or maybe the person, say, just had trauma. Maybe they had a stroke. You probably have heard of the stroke scale. So it's sort of like a mental health scale as well that we assess when a person has such changes. Aphasia, you've learned those terms already. So it's basically impairment in either language, spoken, or understanding comprehension. And then if a person has a mental health breakdown, we do a full mental health exam on the patient. So what are some things that generally contribute to a person's mental health status not being fully functioning? Well, if a person has an illness, that can affect it. If a person has, say, alcohol or substance abuse, that can affect it. Chronic illnesses such as maybe renal disease could cause a person to have, because of the toxicities, mental health disorders. People may be taking medication. We have lots of side effects from medication. That could cause confusion, that could cause depression, that could actually cause the patient to be completely unlike themselves. And then we will look at the patient's behavioral level. We know what patient's baseline is normally, and then with the level of their behavior, you can see that there may be a difference. So we look at the person's response. How does the person respond? Sometimes we see students, when students don't get a good grade on a test, there are some students that it's almost as if there's a fire under their feet at the moment. And that person is way over the top with complaining and blaming, versus a person that didn't get such a good grade, and they calmly accept that, ask appropriate question, and then move along. So we have to look at how a person reacts to certain situations in life as well. If the person's reaction is sort of negative coping techniques, then these are something that we may want to look into. We can do, for objective assessment on the patient, one of the things we can do is a mini mental status exam on the patient. Again, we're going to look at appearance, behavior, cognition, and thought process. So we want to sequence these and make sure that we do it, in order. The first thing would be the person's appearance. So what's their posture? Are they upright, relaxed, or are their shoulders slumped over? Okay. And their body movements, are they deliberate? Is it coordinated, or it's just haphazardly moving? Is it smooth and even, or just disjointed? And what does a person look like? Are they dressed appropriately? If it's 100 degrees outside and you see a person in a long wool coat and hats and mittens, does that seem like it's supposed to be what should be happening with that person? Is that the appropriate dress for that person? Probably not. Even if that person, say, have anemia maybe and they're feeling a little cold, I don't think hats and mitten would be appropriate at that point. So we look at their dress to see if something is going on with the person. We also look at the person's appearance as well. So what is their grooming and hygiene like? Again, like I said before, if they were well groomed and now they're very disheveled, it could give us a sense. And sometimes we see this in nursing students. The student was able to handle things, and then all of a sudden when that student is having a mental health breakdown, that student's appearance changes. They come to class and the hair is not combed, the face is not washed, their clothes all wrinkled, and they don't really give much thought to what their appearance is. So we have to really pay attention, and then of course we'll have to provide some interventions for that as well. Now, be aware that culture plays an influence here, because I'm sure you have seen the guys with the pants hanging down and you're seeing their underwear, right? So it looks like they're wearing their underwear on the outside. Sometimes it's just culture, how the culture dresses. In order to, we may not make assumptions, we have to really ask about it. So just be aware of those things as well. And so for individuals, not everyone have the same amount of finances, to buy the fashionable clothing. Sometimes they wear what they have, and it doesn't necessarily mean there's a mental health breakdown. Some people just want to make their own fashion. Doesn't mean that they have a mental health breakdown. So we also look at their behavior. So level of consciousness. Is the person awake? Are they alert? Okay. Do they really respond to what's going on in the environment? If everyone around them is yelling and shouting and joyful, and they're sitting just not moving or not speaking, then they're off related to what is going on with the appropriate stimulus in the environment. They should be reacting appropriately. Facial expressions as well needs to be congruent with what is occurring, right? A person who, say, was given something that was doesn't make them feel too well, or it would be strange, say, if you give a patient an injection and that person just starts laughing uncontrollably, right? For anybody, an injection would probably cause a little bit of discomfort. So you maybe would see the face, maybe contort a little bit, maybe the patient pulling away somewhat. So you have to look at what is going on with the person and with the stimulus in order to tell. Now, again, pay attention to culture, because there are some cultures that you cannot see what's going on their face because they don't want to show expression, right? Their behavior, their expression on their face. In some culture, they have to be stoic about it. So a person may smile at you and tell you that their pain is 10 out of a 10. And indeed, they're having that much pain. And then another person in a different culture would be screaming their head off, telling you how much pain they're having. So it all depends on culture as well. The speech is very important. It gives us a sense as to what is going on with our patient. So we look at the pace of their speech. If someone is talking a mile a minute to you and you're not able to get a word in edgewise, there could be some problems related to what is going on with the patient mental health wise. If the person is struggling to find words, remember we did aphasia, Broca's aphasia. If the person is struggling to get words out, then we know that there is a particular issue going on, okay? And then the choice of words for the patient also come into play as well. So we need to keep that information as well. A patient may have like dysphonia, which is abnormal volume or pitch. Now, granted, the person doesn't have, say, a hearing impairment, then really they should be able to manipulate the tone and the pitch of their voice, right? But sometimes patients who are monotone, sometimes maybe they're just, a mile a minute. These are patients that could be maybe experiencing a manic behavior. So you have to keep those in mind as well. And then the person's mood and their affect. The affect is what you're seeing on their face, like they're laughing or crying or smiling. Mood is a little bit more, you have to find the information out from the patient. So you ask some questions like, how are you feeling today? So it's more globalized for them to give you the information related to their mood. Now with orientation, I sort of mentioned a little bit earlier about the person being oriented. And as you're doing your head-to-toe assessment, you'll be looking at orientation. So asking the person who they are, their name, and if they give you their name and their age, you need to have something to verify with so that you are aware what their names are as well. And the place. Again, the place doesn't necessarily have to be specifically where they are, that address that they are at that particular time. If they give you a location that is within the city or the state or even the country, we'll take that. And then the time, it could be the day of the week, the date, it could be the year, it could be the season. So these things we give, especially for our older patient. We are a little bit more broad range. Now with attention span, we want to be sure that we're checking a person's attention span. Have you ever been talking to someone and they're there physically, but you know their attention is not there? We sometimes see it happen, of course, to students in classrooms, right? Student body is there, but their brain are far away. So you want to be able to check to see if the person can concentrate. And what we can do is we can give them an assessment. Like I can tell the person to take the glass in your right hand, move it to your left hand, and then put it on the table, right? You're checking to see if that person has good attention span. It's impaired generally in person who are maybe just tired, overly stressed, fatigued, or maybe if the person is intoxicated, they won't be able to follow it very well. Recent memory, we check by asking the person to give us some information about what happened maybe hours ago, 24 hours ago, etc. So you can ask the person, oh, so what did you eat for dinner last night? Or, what did you have for breakfast this morning? That will be recent memory. Remote memory is asking a long-term question. So with remote memory, we ask the patient maybe, what year did you have your first job? Or if it's an older patient, where did you go to high school? Or, what year did you get married? Those things that are long-term. Or what year was your first child born? Those are remote memory that the patient should still have sort of intact. If a person has damaged part of their brain that stores that information, then they're not going to be able to tell you that information, such as people that have dementia or Alzheimer's disease. They wouldn't be able to give you remote memory information, because then that's sort of the axons are getting demyelinated, and so they will not be able to provide that for you. We also look at new learning for a patient, just as we are doing with students as well. The information we're providing is new learning. So how well do our students learn the information? We give the students or patients 4 unrelated words. Now these 4 words cannot have anything to do with each other. So unrelated words. And we ask our patient to try to remember these 4 words that we're actually coming up with. Now, you're also going to be doing additional information or additional things with the patient within that time frame. So 4 words could be like maybe brown, honesty, tulip, and eyedropper. Now they can't match. And then in 5 minutes, You stop whatever it is that you're doing and you ask the patient to repeat those 4 words for you. And then you also check their memory again in 10 minutes and then in 30 minutes. Okay. If the person is having a problem recalling, sometimes we can say, oh, one of the word was a flower. So they're like, okay, tulip. So we can actually help jog their memory in that sense, but we can actually not tell them the information. Now, people with Alzheimer's or dementia generally score 0 or maybe only recall 1 word. And then people with anxiety sometimes have a problem recalling many words. I recall getting a test like this when once someone sort of ran into the back of my vehicle. My head was joggled. I felt like I had a terrible headache. And I just felt like I was in a fog. Now, I thought surely the person was going to give me 4 words to remember. I can remember those. They were like easy words. They told me the words and then they continued talking with me. And then after a few minutes, they asked for the words. And oh my goodness, I was struggling. The words, it was almost like it was in reach, but I couldn't really capture the word. I could probably, I think, remember only one of those 4 words. I thought it's strange, but that's sort of what happens to the brain and when something occurs. So we also look at additional tests that we can do for a person that has aphasia, right? So this is a person that may have had a stroke. We ask them to maybe read something, to write a sentence, to see if they have some comprehension, and to make up a sentence and to write a sentence as well. And at this time, just to remind you about stroke, we use the mnemonic FAST, face, arm, speech, and time. So is the face symmetrical? It should be if they don't have a stroke. Their arms, if it's outstretched in front of them, should not, and their eyes are closed, the arms should both be at the same level. Sometimes with a stroke, there's weakness in one arm, and so you have one arm dropping. And then the speech, is it slurred? Is the patient having trouble speaking? And then time is brain. So always remember, time is brain. So fast. If you see a patient and you do a FAST with them, then they need to get to emergency room right away. Now, thought process, generally the way the person think should be really coherent with our thinking. If I ask a nursing student in 5 years, what do you think you should be? I should get something similar to, okay, I'll be working on a med-surg unit, or I would have gone back and gotten my master's degree in nursing, right? It shouldn't be something like, okay, so in 5 years, I'm going to be playing baseball, you know, with the Arizona Diamondbacks or something. I don't know. That wouldn't make sense for them to be in nursing school right now, and then in 5 years they're going to be playing baseball. That doesn't make any sense. So we have to look at the person's thought process. It really should be logical. The content of what they say really should be consistent, and it really should be logical with what is going on with the person. And then their perception. Sometimes patients have hallucinations, patients have illusions. Now, what is the difference between hallucination and illusion? I'm going to have you guys tell me that maybe in a Zoom session. So patient may not be in reality, right? I'm sure you probably have heard of or seen patients that says, don't you see the bugs crawling on my arm? See the bugs, can't you see it? Right? When there are actually no bugs that are crawling on the patient's arm. Or someone's very paranoid and saying, they're following me. Don't you see them following me? You know, why are they looking at me? So it basically means that the person has some thought-related problems as well. Their thought process and perceptions are not reality-based. A person's judgment, we also look at as well. So it depends on the individuals and it depends on when we are assessing that person as well. We want to test the person's judgment on a daily basis, and sometimes there is an issue. If you know you have to get to class for 9 o'clock and you live 30 minutes away, would you leave your house 5 minutes to 9? If you did, I would have some concern related to your judgment. That would not be good judgment, because you know 30 minutes away is where you live, and leaving 5 minutes, you would not be able to get here on time. So in speaking with the person, we want to look specifically at what they're saying related to what future plans are. Is it realistic for that person? And that especially for patients who are saying going home with medication, etc., you want to make sure that they're given a good rationale, that their judgment would be sound. If the person is unable to do the dressing change because their hands are contracted and nobody lives at home with them, then that person will not be safe to go home. But if they're insisting they're safe, then their judgment may be a little bit off. So we have to really look at what the person says, and is it based in reality? Is their decision-making skills appropriate, or is their judgment appropriate? We also want to screen for suicide in our patients as well. Sometimes we ask the question, well, if I ask about suicide, is that going to make the person, give them the idea that they should go and hurt themselves or try to kill themselves? We do not. It's when we don't ask and the person has had a plan, then they can be in trouble. So we need to be able to ask the information. Now, you're not going to come out initially and say, are you going to kill yourself? You're going to start with very general questions. So how are you feeling today? How are you? Right? Patient may say, I feel down today, or I don't feel happy. And then you further want to explore that. So you start with a very general question and then get right into the heart of it. If your patient mentioned that they're feeling depressed, then you want to say, are you thinking of hurting or harming yourself? And if the answer is yes, you definitely want to know if there's a plan. What is the plan? And of course, if you're inpatient, you want to be sure you don't leave the patient from here on out, that you have eyes on that patient and get some assistance to help you as well. So that patient may need a sitter or someone that is evaluating them all the time, okay? Usually, sometimes when we don't ask the patient the problem, many times the patients that's suicidal, they're asking for help. And so if we don't ask, then that's that one opportunity that you had as the provider in order to provide help and you didn't. The other thing is, someone is telling you this information and telling you to keep it a secret, please just remind them that for their safety, you cannot keep anything a secret. And that goes for anything in healthcare wise. You're not the final arbiter of that information. So you need to pass it on to someone else. It could be a social worker, the physician, your nurse manager, whomever. It needs to go beyond you. Never share secrets or tell patients you will keep their secret. We do no such thing in nursing, okay? Sometimes it's just to buy time so that they can get some help. So one of the exams that we do with the mental health status is do a mini mental exam on patient, and that looks at the patient's cognitive functioning. So there are quite a few questions that is asked, and it tells how badly that person is having a problem with their mental status, if it's getting worse. If the screening is appropriate, then it can actually pick up that the patient has dementia or delirium. And normally it doesn't take that long. And some of the questions would be like asking the patient to draw objects, maybe draw some things, maybe count backwards, etc. We can also do a mini cog or mini mental exam on the patient. And what that entails is actually giving the patient 3 words to recall, and then you actually check their recall in a few minutes. You're also going to give them something like a clock face for them. Tell them to draw a clock face and then give them a time like 9:20 and see if they put the hour hand in the right place. Sometimes patients that have a mental health problem disorder end up switching the hour and the time, the minutes hand. Flip that backwards. So we generally want to screen our patient with impairments. Now, if the person has some additional problems, sensory problems, like if they wear glasses, make sure they have the glasses on before they actually take this test, because they'll be drawing incorrect because they couldn't see, not because there's a mental health disorder going on. So just be aware of some of those things, please. So Again, here, check the patient's sensory status, or maybe their hearing status. Maybe the hearing aid was not in, so that's why they couldn't hear you, why they gave the wrong information. It's not that they have a mental health problem. So with infants and children, the mini or mental status exam tell us how the child is coping with the environment. Okay. The other thing is what it gives us information on if that patient has reached developmental milestones. Because remember, with infants, we cannot separate those different parts. Everything is interrelated, related to the child's mental health. So we're looking to see if they have reached appropriate milestones. Also, when we are doing the assessment, we look at A, B, C, T in order to guide us in doing the assessment itself. For infants, we can use something like the Denver 2 screening, or their scales, and it tells us if the person has developmental disabilities, and also it identifies children who are either slow in their behavior, in their language, maybe even psychosocial behaviors as well. So there are different scales that we can actually utilize with the infant. Now, their level of consciousness, we actually use like the Glasgow Coma Scale in the hospital, and that look at testing a few things. So we'll review that in just a moment. But it gives us a sense as to what the patient's functioning is at the moment. So we can look at their eye opening, their verbal response, and then their motor response. So when I walk into a patient's room and I say, "Good morning, Miss Jones," Miss Jones should automatically open her eyes and say good morning, right? But if I keep saying good morning, Miss Jones, and Miss Jones is not opening her eyes, and then if I yell a little bit louder, good morning, Miss Jones, nothing from Miss Jones. And if I knock, bang, 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 knocking on the door, good morning, Miss Jones, and absolutely nothing from Miss Jones. Now here it is, I am increasing my stimulus to the patient. So much so that now I'm going to have to go over to Miss Jones and physically touch Miss Jones and try to shake Miss Jones to see if she's awake, gently, of course. And it's not going to take that. So again, my stimulus is increasing. Maybe I have to do painful stimulus at this time in order for Miss Jones to be awake. So just be aware of the patient's level of consciousness. So the Glasgow Coma Scale uses numbers to determine whether eye opening was spontaneous or eye opening was to a painful stimuli. And so everyone will be able to tell exactly where we are. And this is exactly what it looks like, the caption on the left. So if they open their eyes as you call their name, that would be given a 4. And if they open their eyes to pain, that painful stimulus on the patient, like maybe rubbing their sternum, a sternal rub, that would be a 2. No response would give them a 1. Now, the lower the score is, the Glasgow Coma Scale, is the worse it is for the patient. So the higher the score, the more alert and awake your patient is. So we look at eye opening, we look at verbal response. The patient was oriented when they responded with their name and where they were. Or maybe it was they use inappropriate words to tell us, like if I asked, Miss Jones, where are you? Blue, kitten, red, right? That makes no sense. So inappropriate words, or they try to make up word, like a word salad, that would give a 2. And then best motor response would be if I say, Miss Jones, can you raise your hand above your head? And she did that. That would be obeying the command. That would give her a 6. Or if Miss Jones doesn't do that and cannot lift that hand, cannot even extend the arm. Miss Jones, extend your arm, stretch your arm out, and absolutely nothing from Miss Jones, then she would get a 1 for that. So some other findings would be a patient being lethargic, like really somnolent, very sleepy here, or a patient being sort of comatose or semi-comatose. So we know what a patient look like when they're in a coma, right? Nothing from the patient. They're completely unaware of what's going on. Obtunded generally would be a patient that is maybe under the influence of substance. Like if you see a person that was drunk, we say that they're obtunded. And then maybe a person having hallucinations versus illusions. And again, you're going to tell me what those two, how those two are different. So delirium is basically a change in a person's cognitive status, and that is over a period of time. So a person can be admitted to the hospital, go into the ICU, and we've kept the person in the ICU for a few days, and all the lights are on, even at midnight, 2 o'clock in the morning. So the person have no clue. There are no windows. They don't know when it's daytime, when it's nighttime. Everything looks the same, and we're always going in to wake the patient up. So the person can become a little bit confused. We call that ICU delirium, okay, or ICU psychosis. Versus dementia. Dementia is a more longer-term memory impairment that can happen. And this would be for a patient that say have Alzheimer's, okay? And then a person with depression is a mood disorder that occurs over a period of time. Not just feeling sadness for a moment, but it's more long-term. So which of the following basic functions should the nurse test in an assessment of mental status? Is it behavior, language, judgment, or consciousness? And your answer is consciousness. The nurse understands that all of the following components of a mental status assessment, all of the following are components of the mental status assessment, except is a cultural background, known illness or health problems, current medication, known to affect mood or cognition, or personal history, current stress, social habits, sleep habits, and drug and alcohol use. The answer is everything except cultural background. And then we would document the patient's appearance, what they look like, how they're dressed, their behavior, okay? So everything that the patient would give us information, they would tell us if they're able to repeat those words. And then of course, objective data would be documenting objective data. So which of these two individuals would you say have a mental health problem? One on the left, one on the right. Now, if your answer is, I can't really tell because you can't tell by the picture, then you probably will be correct. But the one on the right was actually Jack the Ripper. Okay, so if you guys are too young and don't quite know who Jack the Ripper is, since we are all on the electronic databases, you can actually look up who that person is. So you can do that for homework. And the one on the left, who do you think he is? I can tell you that he plays sports. So here are some websites that may be of interest to you or to future patients. Now let's move to substance abuse in Chapter 6. We're going to look at risk factors related to alcohol use, identify some statistics related to substance use, and look at substance use across the lifespan. So alcohol is most widely used psychoactive drugs with our patients. Every year, number of patients die from alcohol use, especially our young people. The emergency department see a lot of patients, and one of the major issues is because of alcohol use. So alcohol can also cause cirrhosis, can cause cancers of the esophagus, the pharynx, the liver, and then it can cause injuries to other organs as well. Now, is it appropriate for a pregnant woman to use alcohol? The answer is no, although there may be some physician, obstetrician, who tells pregnant women that it's okay to drink a glass of wine here or there. No amount of alcohol for that pregnant patient is appropriate, okay? Now, women who use alcohol, actually the rate of breast cancer increases in a dose relationship. So if you drink 1 drink versus 10 drinks, if you drink 10 drinks, you're going to be more at risk than if you just drink 1 drink. You're still at risk, but it's not as bad as if you drink 10 drinks. I am not saying that you can have 1 drink. No amount of alcohol is appropriate for anybody in my book. However, so chronic alcohol use and liver disease, we know that. We know it causes cirrhosis of the liver, so we teach our patient not to do so. Heavy alcohol use can actually also cause cardiac issues as well. It cause the veins to dilate in the vessel wall. It causes thinning of those vessel wall. So think about your patient who's going to have an aortic aneurysm because those vessel walls have now gotten so thin, right? Also, it can cause hypertension in patients as well. So alcohol use causes a patient to really die. So the morbidity, mortality is increased in patients, especially if patients have alcohol use and they go into the ICU, chances are they may not be coming out, or a small amount of patients will make it out of the ICU. So excessive alcohol use increases the risk for ICU admission. Okay. So a drink a day may increase the risk of breast cancer. That's per a new study. Okay. And also, alcohol can raise the risk of breast cancer by 5% in premenopausal women and 9% in postmenopausal women. So 9% of Americans who are, these are kids, teenagers, preteen, 12 years old, report using some kind of illicit drugs. Of course, where are they going to find the drugs? In parents, at home, in the cabinets, etc., or maybe from friends. So illicit drug use is basically marijuana. Now I know that marijuana is now legal in some areas, but not every area. Also cocaine use, etc. But marijuana is the most commonly used illicit drug by people who are 12 years old and older. We also have an abuse of oxycodone, hydrocodone, and methadone as well. So just be aware, people that are actually taking methadone to help substance abuse, they can also be abusing those drugs. So we know that alcohol passes through the placenta, right, which is why none of it is good for the pregnant woman. However, you can see on the screen that even though women are aware, we have 3.7% report alcohol use even in their third trimester. So that's terrible. So we continue to do teaching about abstaining from alcohol use while being pregnant because it does affect the fetus. I don't know if you've ever heard of fetal alcohol syndrome, babies that are born, abused to alcohol or going through withdrawal from alcohol. It's generally really sad. In our patients that are older, we see alcohol use as well. So patients that use alcohol, 41.2% use alcohol. This is over 65 now. Okay, 8.2% binge drink, and you can see the statistics on the screen itself. So what increases the risk for the older patient would be liver metabolism. Okay, remember everything is sort of either slowing down or they're losing things in the older age. So the liver doesn't metabolize as much because we're losing tissue, and so it's going to put the patient at risk. They're going to be a little bit more toxic, right? So alcohol is going to stay in their body for a longer period of time. So less tissue mass is what they're going to have. Alcohol can also interact with medication, and our older patients are generally on more medications. They take hypertensive, they are on maybe aspirins or maybe antidepressants, who knows. They take a lot of medication. Alcohol also increases the risk for falls in our older patient as well. Then it can cause depression, GI problems, and we know that the bone is not as strong for the older adults. And if you make them fall or cause them to fall with alcohol use, then sometimes an older patient breaking a hip is basically the end of that patient. So subjectively, we'd like to ask patients questions when they come in. Now, if a patient come in and they're under the influence of substance, just know that you're not going to get appropriate information. And also, some patients are belligerent when they're using alcohol or other substance. So your safety is key. Always make sure that you have an exit, that the patient is not between you and the exit. So just be aware of those as well. Ask about alcohol use. In general, when your patient gives information, they tell you that they use much less. So we actually have to double or triple what they say in order to get a good sense as to how much they're using. But you want to ask those questions of how many drinks they would have had. and when the last time was that they had the drink. So how do we know if a person has been drinking? Well, we can do some objective tests to tell us. We can draw blood levels, so serum level. We look at the serum protein, we look at GGT, and it's used for a person that actually, if they're occasional drinkers, it will not raise the level, but when they're chronic drinkers, this is where we see the GGT level in the patient. So if they say, oh, no, I've not had an alcoholic drink in like 6 months, and you draw the serum and you see positive GGT levels, then you know that they weren't being honest with you. And then there's some other tests as well. We can look at the complete blood count, mean corpuscle volume, which is MCV, in a patient, and that is the size of the red blood cells. It will increase if that person has, say, the last few weeks have had heavy drinking. So MCV, the level will actually go up. We can also do a breathalyzer as well, where patients breathe into a piece of equipment if they've ingested alcohol recently. So this is the test that actually, if you're pulled over by a police officer, they would administer and look at what your blood alcohol level is. And of course, I think in Florida, it's on your license that if you refuse it, your license can actually be removed from you. So just to be aware of this information. So for substance use, we do ask some questions related to substance use. Some of the questionnaires we utilize would be like the CAGE questionnaire. And if you look in your book, page sort of 93 and 94, it gives you some information on what the type of questions are for the CAGE questionnaire. We also do use the CWAS scale, which is a clinical scale that we use to assess withdrawal from our patient as well. Now, going back to the CAGE, since I didn't identify it, so let me just identify it for you. The CAGE questionnaire would be asking, the C stands, each of those letters stand for something. So the C is for cut down, the A is for annoyed, the G is for feeling guilty, and E is for eye-opening. So if a patient, you may ask a patient, do you feel guilty after drinking? Or is anyone annoyed at your drinking? Or do you feel you need to cut down on your drinking? And do you need an eye opener or a drink in the morning to get your eye open? So that's what the CAGE questionnaire is. Now, after a while, patient develop tolerance, so which means they need to drink more in order to get them to feeling that they once had, right? Also, some things that you can see when you're assessing your patient. If a person is under the influence of cocaine and they're intoxicated with these substances, you can look in their pupil and see dilation of their pupils. If they're going through withdrawals, you'll see psychomotor agitation. These are patients that cannot keep still. They have to be moving around a lot. If they were using opiates like heroin, when you look in their eyes, you'll actually see pinpoint pupils. If they were going through withdrawals, they'll actually have what looks like flu-like symptoms, nausea, vomiting, etc. So a nurse is caring for a patient in the ED who has been a patient many times before. In fact, this is the patient's second overdose in 1 month. The nurse says, here we go again. I don't know why we bother with this guy because he'll be back here as soon as he's discharged. So which of the statement best reflects the most appropriate behavioral response from the nurse? Is it 1, 2, 3, or 4? So your answer is 4. The nurse must find a way to come to terms with the way he or she feels about those types of issues and work on ways to deal with them. So we have to treat every patient appropriately. It doesn't matter if this is their 50th time. This could be the very time that they're willing to accept some help. The nurse is assessing a patient who's been abusing opiates for 4 years. The patient says, I can quit anytime I want. The nurse should interpret this statement to be a sign that this individual, is it 1, maybe in denial of needing help or having a problem with opiates? 2 is ready to quit and can do so with little intervention. 3 is motivated to enter rehab. Or 4 should not be trusted because this individual is not of sound mind. Your answer is 1. They're in denial. Any questions? Okay. Thank you for listening.